In contemporary clinical cardiology, systemic thrombolysis or fibrinolysis has shifted from being treated as a standalone reperfusion endpoint into pharmaco-invasive strategy. While primary percutaneous coronary intervention remains the definitive class 1 reperfusion standard for ST segment elevation myocardial infarction or STEMI, fibrinolysis remains the essential first-line reperfusion vector whenever timely mechanical reperfusion is unfeasible, particularly in geographically dispersed regions and non-primary PCI capable facilities. Current European Society of Cardiology and American College of Cardiology, American Heart Association guidelines enforce strict temporal metrics to minimize total ischemic time. The 120-minute gait. When a patient presents to a non-primary PCI capable facility or emergency medical services, the clinical team must calculate anticipated delay. If time from first medical contact to cath lab wire crossing is anticipated to exceed 120 minutes, fibrinolytic therapy must be initiated immediately. Door to needle benchmark. When indicated, lytic administration should occur within 30 minutes of hospital arrival or ideally in the field via pre-hospital emergency medical services protocols. The transfer mandate. Standalone thrombolysis without subsequent institutional transfer is obsolete. Every lyse patient must be systematically transferred to a PCI capable hub as early as feasible. Once fibrinolysis is administered, post-lytic clinical triage dictates the catheterization laboratory schedule. Rescue PCI immediate, mandated if fibrinolysis fails. Failure is defined clinically by less than 50% ST segment resolution at 60 to 90 minutes post-bolus, persistent hemodynamic instability, cardiogenic shock, or ongoing ischemic chest pain. Routine early angiography 3 to 24 hours, mandated for all patients with clinically successful reperfusion. Critical window nuance. Performing routine angiography under 2 to 3 hours post-successful lysis significantly elevates access site and systemic bleeding risks without improving infarct-related artery patency. Conversely, delaying beyond 24 hours forfeits the opportunity to secure the residual unstable plaque before reocclusion occurs. Third generation tenecteplase TNK-TPA has firmly supplanted second generation alteplase and first generation streptokinase as the global standard of care. Engineered via 3 specific amino acid substitutions on the human tissue plasminogen activator backbone, TNK offers distinct pharmacokinetic advantages. Administration. Single weight adjusted IV bolus 5 to 10 seconds for TNK-TPA, front loaded bolus plus 90-minute infusion for alteplase. Fibrin specificity high, 14-fold greater than native TPA. Alteplase moderate. Plasma half-life 20 to 24 minutes for TNK-TPA, 4 to 5 minutes for alteplase. Plasminogen activator inhibitor resistance high, 80-fold greater resistance for TNK-TPA, while alteplase is highly susceptible to rapid inhibition. TIMI3 patency rate 60 to 65% at 90 minutes for TNK-TPA, 50 to 60% at 90 minutes for alteplase or RTPA. The single bolus dynamic of TNK is transformative for pre-hospital care, allowing solo paramedics or rural physicians to execute rapid reperfusion without managing complex, fragile weight-based IV infusion pumps during transport. Contemporary adjunctive pharmacotherapy. Fibrinolysis exposes highly thrombogenic plaque core surfaces and triggers paradoxical thrombin activation. Achieving lasting vessel patency requires aggressive adjunctive antithrombotic coverage. Dual antiplatelet therapy, aspirin combined with clopidogrel. Newer potent P2Y12 inhibitors like prasugrel and ticagrelor are contraindicated at the exact time of fibrinolysis due to unacceptable intracranial hemorrhage risk, though downstream switching post-angiography is quite common. Anticoagulation. Intravenous enoxaparin is superior to unfractionated heparin for preventing infarct-related artery reocclusion. Dosing must be strictly adjusted for patients over 75 years old and severe renal impairment. Intracoronary lysis during primary PCI. In cases of massive thrombotic burden during mechanical intervention, low-dose intracoronary tenecteplase or alteplase is gaining clinical traction as an adjunctive bailout to dissolve microvascular emboli and resolve slow flow or no reflow phenomena. Artificial intelligence triaged pre-hospital networks. The expansion of cloud-connected 12-lead ECG transmission analyzed instantly by remote AI algorithms is compressing diagnostic delays, shifting the therapeutic goalpost from door to needle to first contact to needle directly at the patient's bedside.